Usually when we think about a medical setting, there is this expectation of just absolute clear-cut precision, like engineering.
Right, yeah, like a machine.
Exactly. You break your arm, the X-ray shows that jagged white line, and the doctor just points and says, there it is.
It feels incredibly binary from the outside. I mean, the bone is broken or the bone is not broken. It's a clean, solvable equation.
Right. And we crave that. We like things to be visible, to be, perfectly categorized. But then you look at what actually happens on a hospital floor minute by minute, and suddenly that X-ray machine is just a tiny, static piece of this massive, constantly shifting, just chaotic puzzle.
Well, absolutely. It's organized chaos.
So today, we are taking on a mission for you, the listener. We want to decode the invisible cognitive machinery of the people actually running that floor. We're looking at how nurses actually think, how they make those split-second life or death decisions, and how they manage to avoid being completely overwhelmed by sensory overload.
Because there is a lot of sensory overload.
Tons of it. We're pulling from Dr. Biru's presentation, Nursing Process 1 and 2, and the book Surviving Nursing School, to really understand how raw, terrifying patient data gets translated into action. Okay, let's unpack this, because nursing is so often described as this blend of science and art.
Yeah, that translation process is what we are really dissecting today. We're going to explore two major frameworks that govern this. The first being the foundational behavioral framework called the nursing process, which is often referred to as ADPIE.
ADPIE.
Right.
Catchy.
It is. And the second is the clinical judgment measurement model, or CJMM. That's the newer cognitive framework used by the next generation NCLEX. By the time we are done, you'll understand how a professional can walk into a room where alarms are blaring, a patient is crashing, and, instantly sift through the noise to find the exact right lever to pull.
And when you're just a patient or a visitor on the outside looking in, it can look deceptively like just a series of disjointed tasks. You see someone checking vitals, handing out a little cup of pills, typing on a computer on wheels.
Right, it looks like a checklist.
Yeah, it looks exactly like a checklist. But what these sources reveal is that it is an intense, real-time cycle of analysis.
The checklist illusion is super common, but it misses the immense intentionality behind every single action. The traditional framework that has guided this intentionality for decades is the nursing process.
Right, the ADPIE thing.
Exactly. It's built on 5 pillars: assessment, diagnosis, planning, implementation, and evaluation. It's a deliberate, cyclic response to a patient's situation.
Deliberate is really the operative word there. Let's dive into that first pillar, assessment. The great data hunt, basically. The way I like to picture this, and think about this the next time you find yourself in a hospital room, is like a courtroom trial.
Oh, I like that analogy.
Yeah, because when a nurse is assessing a patient, they are acting as an investigator, gathering two very different types of evidence. First, you have subjective data. This is basically the witness testimony.
Right. It's what the patient says.
Exactly. It's what the patient or their family actively tells the nurse. I feel dizzy, or my chest feels heavy, or I'm nauseous.
And just like in a courtroom, witness testimony is crucial for pointing you in the right direction, but, it is notoriously subjective. Patients might minimize their pain because they want to go home, or they might just struggle to articulate exactly what's wrong.
Right. They might just say, I feel weird.
Yeah. And you can't base a life-saving intervention entirely on that testimony. You need the hard forensic evidence. In nursing, that is the objective data.
Because you can't fake the forensics?
Never. The objective data is what the nurse observes, physically measures, or, pulls from lab records. It is the palpable swelling around a surgical site. It's the blood pressure reading of 90/60.
The actual numbers.
Exactly. It's the oxygen saturation level. This is the irrefutable data that grounds the subjective complaints in physical reality.
But gathering that forensic data isn't just a matter of, glancing at the patient and writing down a few numbers. The source material details some incredibly specific, highly calibrated tools nurses use to standardize this collection. It takes all the guesswork out of observation.
Oh, absolutely. They don't just guess.
Right. For example, they mentioned the Braden scale.
Yeah.
I always assumed assessing a patient's skin just meant, looking for cuts or bruises.
The Braden scale is a perfect example of looking deeper than the surface. It's used to assess a patient's risk of developing pressure ulcers, what we commonly call bed sores.
Which are awful.
They are. But the scale doesn't just ask, does the skin look okay right now? It forces the nurse to systematically score the patient's sensory perception, their skin moisture, their physical activity, and their mobility.
So if a patient is immobile and they have a fever causing them to sweat, That moisture, combined with the inability to shift their weight, creates like a high-risk environment for their skin to literally break down.
Exactly. And skin breakdown in a hospital can lead to severe infections, sepsis, and even death. So assessing moisture isn't about hygiene, it's a vital preventative measure.
Wow. And they use similar tools for the brain, right?
Yeah, like the Glasgow Coma Scale, which measures eye, verbal, and motor responses to give a highly specific number regarding a patient's level of consciousness, or the CAGE and CIWA scoring for patients who might be experiencing alcohol withdrawal.
So the nurse is just constantly running your presence through these standardized filters. Which brings us to the next pillar, diagnosis. Now, I have to admit, I was looking through the list of diagnoses in these notes, and I was genuinely confused.
Really? How so?
Well, if a patient comes into the ER and the attending physician already diagnosed them with pneumonia, why is the nurse writing down a completely different diagnosis? Isn't pneumonia enough to get to work? It feels, I don't know, redundant.
What's fascinating here is the hidden brilliance in that very crucial distinction. A medical diagnosis identifies the specific disease or pathology: pneumonia, congestive heart failure, type 2 diabetes.
Like the actual disease.
Exactly. The physician's primary job is to cure or manage that underlying pathology. That medical diagnosis remains the exact same for as long as the disease is present. But a nursing diagnosis identifies the human being's response to that illness.
Their response. So it's not about the microscopic bacteria in the lungs. It's about what those bacteria are actively doing to this specific person's life right now.
Exactly that. The nursing diagnosis is dynamic. It changes shift by shift as the patient's needs change. So the medical diagnosis is pneumonia, but the nursing diagnosis might be impaired gas exchange because their lungs are currently filling with fluid.
Okay, I see.
Yeah, and a day later, as the antibiotics kick in, their breathing might improve, but the coughing has left them exhausted. So the nursing diagnosis shifts to activity intolerance.
That makes a ton of sense.
Yeah.
You could have two patients in a shared room, both with the exact same medical diagnosis of pneumonia. But patient A gets a nursing diagnosis of impaired gas exchange because their oxygen is tanking, while patient B gets a nursing diagnosis of anxiety because they are terrified they won't be able to go back to work.
Yes. The nurse has to treat those two very different responses, and those responses are meticulously standardized by an organization called NANDA, the North American Nursing Diagnosis Association.
So it's not just a free-for-all.
Not at all. A proper nursing diagnosis isn't just a gut feeling. It follows a specific three-part formula. First, the problem label. Second, the etiology or the cause, which is usually written as related to.
Okay.
And third, the defining characteristics, which are the signs and symptoms written as evidenced by.
So it looks something like impaired gas exchange related to alveolar capillary membrane changes, as evidenced by an oxygen saturation of 85% and severe shortness of breath. It is almost mathematical.
It really is. But getting to that precise formula requires a massive amount of critical thinking. The presentation spends a surprising amount of time discussing the internal mindset required to do this fairly.
Yeah, because diagnosing a human being's response requires recognizing your own inherent biases. The literature highlights a fascinating tension between egocentricity and sociocentricity.
That part is huge. Egocentricity is our natural human default, thinking of ourselves, our own convenience, or preconceived notions.
Wow.
If you are a nurse at hour 11 of a grueling 12-hour shift, your egocentric brain might look at a lethargic patient and think, they're just sleeping, let them rest.
Because that is easier for you.
Right. But sociocentricity, thinking of the greater good and the patient's objective reality, forces you to check that assumption. It requires intellectual humility.
You really have to second-guess yourself.
You do. It forces you to ask, are they just sleeping? Or is their level of consciousness actually deteriorating because their brain isn't getting enough oxygen? You have to constantly battle your own fatigue and biases to see the patient clearly.
So you've gathered the forensic evidence, battled your own biases, and formulated a highly specific diagnosis of how the patient's body is failing. Now what? Because this brings us to the planning phase.
Yes, step 3.
And frankly, a hospital is a chaotic environment. Every alarm is beeping. Everyone needs something. How does a nurse know what to do next?
Well, this is where prioritization stops being a corporate buzzword and becomes a vital survival skill. Nurses rely heavily on foundational frameworks to determine what requires immediate Drop everything attention.
The big ones, right.
Yeah, the absolute bedrock is Maslow's hierarchy of needs, combined with the ABC framework: airway, breathing, circulation.
The notes provide a really stark example of this. You have patient A who has an oxygen saturation of 82% and is struggling to breathe. And then you have patient B who is reporting chronic arthritis pain at an 8 out of 10.
Right, a classic scenario.
For the layperson, pain sounds like the ultimate emergency. But it's like the nurse has to act as an incredibly ruthless ER bouncer.
Triage can feel brutal from the outside, but it is mathematically necessary. Patient A gets priority every single time. Airway and breathing will always, unconditionally, trump chronic pain.
But the material emphasizes that patient B is not being ignored. They're just being treated after stabilization. It is a matter of immediate lethality versus chronicity. The nurse's brain has to instantly rank human suffering based on what will kill someone first.
Exactly. And once they have prioritized the most lethal threat, they have to formulate a plan. They use SMART goals. You see this everywhere in the corporate world: specific, measurable, achievable, relevant, and time-bound.
Yeah, but there's a massive difference between setting a SMART goal to, like, increase quarterly sales by 10% by Q3 and setting one in a medical crisis.
Yeah, the stakes are slightly different. Instead of a vague goal like make the patient breathe better, the nurse's SMART goal has to be bulletproof. The patient will maintain an oxygen saturation greater than or equal to 92% within 30 minutes of nursing interventions.
Which naturally drives us into implementation, the actual physical actions taken to achieve that goal. Nursing interventions fall into 3 distinct buckets, right?
They do. First, you have independent interventions. These are actions the nurse is licensed to take completely on their own without waiting for a physician's order.
So things they can just do immediately.
Right. This includes physically repositioning the patient in bed to open up their airway, providing emotional support, or implementing safety protocols like raising the bed rails.
Then you have dependent interventions. These are the big guns that technically require a provider's order, like administering medications, starting 5E fluids, or applying oxygen. Because technically, oxygen is considered a drug.
It is. And finally, collaborative interventions. This is the team sport aspect of healthcare. The nurse might collaborate with respiratory therapy to manage a ventilator, or work with a dietitian to ensure a diabetic patient is getting the right macros.
Okay, so you've assessed the data, diagnosed the response, planned your SMART goal, and implemented the interventions. You've given the oxygen, you prop them up. So what does this all mean? Are you done? Do you move on to the next room?
The process would collapse if it stopped there. The final pillar of the nursing process is evaluation. Closing the loop, the nurse must physically return and check if the SMART goal was actually achieved.
You have to compare the reality against the expectation. If the goal was 92% oxygen saturation and the patient is now sitting comfortably at 95%, the goal is met.
Right, and if it's only 90%, it's partially met. And if it's still 85%, the goal is not met at all.
And if it's not met, the entire cycle starts over. You assess again, why didn't the oxygen work? Did the tube slip out? Is there fluid in the lungs preventing absorption?
Exactly. You diagnose the new barrier, plan a new goal, and implement a new intervention. And crucially, every single step of this cycle must be documented.
The old saying, if it wasn't charted, it wasn't done.
Exactly. Documentation isn't administrative busy work. It is the legal, permanent record of the forensic evidence gathered, the clinical judgment applied, and the outcome achieved. It protects the patient, and it protects the nurse's license.
Now, as I was reading through Dr. Biru's presentation, I kept thinking about the speed of all this. The nursing process, ADPIE, is a brilliant way to organize a chart. It tells you what steps to take. But it feels incredibly methodical.
It's very linear on paper.
Right. Almost slow. It doesn't really explain how the human brain processes the sheer, terrifying chaos of a patient crashing in a matter of seconds.
You've identified the exact limitation that led the entire nursing profession to evolve its educational framework. ADPIE is a behavioral model. It described the physical actions and the paperwork.
But not the thinking part.
Right. But clinical judgment, the actual invisible firing of synapses under pressure, is cognitive. And that requires a different map, which is the Clinical Judgment Measurement Model, or CJMM.
Developed by the National Council of State Boards of Nursing for the Next Generation, NCLEX.
The boards of nursing recognized a critical issue. They found that new graduate nurses weren't making clinical errors because they lacked factual knowledge. They knew the textbooks.
What was the problem?
They were making errors because they lacked clinical judgment. They couldn't connect the dots fast enough in a chaotic environment. So the NCSBN had to figure out a way to measure and test how a nurse thinks, rather than just testing their ability to memorize a checklist.
So they broke down the invisible cognitive machinery into 6 specific skills. Let's walk through these, because this is where the magic really happens. Step 1, recognize cues.
Right.
This is the ability to walk into a room and instantly filter out the irrelevant noise to find the blinking neon signs.
Exactly. And step 2 is analyze cues. Taking those isolated blinking signs, comparing them to the patient's baseline, and linking them together to form a coherent picture of a potential problem.
Okay, so you see the signs, then you figure out what they mean. Step 3, prioritize hypotheses, deciding which of those potential problems will kill the patient first. They use an expanded triage method here called ABCDE.
Yes. Airway, breathing, circulation, disability, and exposure. Then step 4 is generate solutions. Rapidly building a mental menu of evidence-based interventions that will directly target the highest priority hypothesis.
Step 5, take action.
And finally, step 6, evaluate outcomes.
Wait, recognizing cues, that's just gathering data. Analyzing cues, that's formulating a diagnosis. Generating solutions is planning. Are these just the exact same thing with different labels?
You just hit the nail on the head. The CJMM overlays perfectly onto the traditional nursing process. Recognizing and analyzing cues maps directly to assessment and diagnosis.
Okay, yeah.
Generating solutions maps to planning. But the distinction between the two models is the key to mastering the profession. The nursing process is the external action plan.
The paperwork.
Right. It is what the nurse physically does and writes down. The CJMN is the internal monologue. It is the lightning-fast cognitive machinery that allows them to execute the external plan under extreme pressure.
Oh, wow. Here's where it gets really interesting. To really feel the weight of this dual processing, we need to put you, the listener, right in the shoes of a nurse walking into a crisis. Let's look at the specific clinical scenario provided in the text. The crucible.
Okay, picture this. You have just walked into the room of a 72-year-old patient admitted with pneumonia. You cross the threshold, and a tidal wave of raw data hits your senses.
The patient's temperature is 102 degrees Fahrenheit. Their respiratory rate is 30 breaths per minute. Their heart rate is 118 beats per minute. Their oxygen saturation is sitting at 85%.
That's a lot to take in at once.
And there's more. You listen to their chest and hear crackles, the sound of fluid in the lungs. They have a productive cough, and they are experiencing severe dyspnea, visibly gasping for air.
For context, a healthy person sitting on their couch has an oxygen saturation hovering between 98 and 100%. At 85%, this patient's vital organs are actively starving for oxygen.
It is a terrifying amount of data.
It really is. An untrained person would just freeze in panic. But let's slow down time and look at how the nurse's brain processes this simultaneously through both models.
Starting with the internal mind, the CJMM. Instantly, the nurse recognizes cues. They hear the fast breathing, they see the 85% on the monitor, they hear the crackles.
Their brain rapidly analyzes those cues. It links the low oxygen and the crackles together to form a terrifying picture of severely impaired oxygenation.
Next, they prioritize hypotheses. Using the ABCs, the nurse mentally pushes the 102-degree fever and the rapid heart rate down the list. Airway and breathing are the immediate threats.
Yeah, the heart rate is likely just a secondary response to the lack of oxygen anyway.
Makes sense.
So they generate solutions. A mental menu pops up. We need to administer supplemental oxygen immediately. We need to change the physical geometry of their chest to help them breathe. And we need continuous monitoring.
And that all happens in the blink of an eye. Now let's look at the external action, the nursing process. Based on that lightning-fast internal cognition, the nurse formulates the formal diagnosis.
Right, the NANDA one.
Exactly. Impaired gas exchange related to alveolar capillary membrane changes secondary to pneumonia, as evidenced by an oxygen saturation of 85%, dyspnea, and crackles.
Then they establish their SMART planning goal. The patient will maintain an oxygen saturation greater than 92% within the next 30 minutes.
Then they move to implementation. They take action. They don't have time to track down a physician for the independent interventions. They immediately grab the bed controls and put the patient in a high Fowler's position.
Sitting them straight up at a 90-degree angle to let gravity pull the abdominal organs down, maximizing lung expansion.
Right. And they administer the prescribed oxygen therapy. They verbally coach the panicked patient to take slow, deep breaths.
And then the loop closes with evaluation. They stand at the foot of the bed, watching the monitor. The oxygen saturation slowly ticks up, 85, 88, 91, 94%.
Goal met.
Crisis averted.
It is an incredible moment of clarity when you see it laid out like that. Through this synthesis of the internal cognitive model and the external behavioral process, you can clearly see how raw, terrifying medical data is wrestled into a calm, systematic, life-saving resolution.
It really demystifies the magic of healthcare and replaces it with something even more impressive, rigorous, highly trained cognition.
It really does.
If we connect this to the bigger picture, it proves definitively that nursing is so much more than following doctor's orders or completing tasks on a shift. It is advanced clinical reasoning. It is high-level prioritization.
It's essentially rapid pattern recognition in an environment where the stakes literally could not be higher.
Exactly. That is why the educational models evolved to focus on how nurses think, because that specific type of thinking is the ultimate safety net for the patient.
As we wrap up this deep dive into the architecture of clinical decision-making, I want to leave you with a final thought. We've spent our time today exploring how nurses use frameworks like the CJMM to instantly cut through the chaos, filter out the noise, and prioritize hypotheses in literal life or death situations.
Real-world superpowers, basically.
Yeah, exactly. But think about your own daily life. Think about your own work. When you are faced with a completely overwhelming, high-stress emergency, maybe a massive project is falling apart at work, or you are navigating a chaotic family crisis.
The moments where the metaphorical alarms are blaring.
Right, and every single demand feels equally urgent. How could you apply this exact same cognitive machinery? What if, instead of letting your egocentric panic take over, you stopped to systematically recognize the actual forensic cues of the situation?
Analyze the real underlying problem instead of just the symptoms.
Exactly. Prioritize your hypotheses based on what is truly the most critical, and generate solutions before taking action. If this mindset can pull a 72-year-old patient back from the brink of suffocation when the medical picture gets terrifyingly murky, just imagine the clarity it could bring to the chaotic emergencies of your own life.
That's a really powerful way to look at it.
Keep exploring, keep questioning, and we will see you on the next deep dive.